Today's inspirational is about the clinical interpretation of resisted functional tests. In the extremities, the upper extremity, the lower extremity, we frequently use resisted tests in our functional examination procedure. But the question is, of course, what exactly do we test? Well, on doing a resisted test, a maximal isometrical contraction from, if possible, a neutral position, we always test what happens with the pain. Does the pain increase, decrease? Do we produce some pain somewhere else? And what happens with force? Is there any weakness, yes or no? If we have a more detailed look at it, the ideal situation is that one or more resisted tests are positive, but there is no weakness, so force is okay. In that case, we can often think of some moderate muscular or tendinous problem. Another case in which the resisted test is painful, but there is also weakness, then the diagnostic options are a little bit different. One option could be a partial tendinous rupture, but another option could be a fracture. For instance, weakness on resisted elbow extension is something we're going to find in case of an olecranon fracture. Or weakness on resisted knee extension also occurs in the case of a patella fracture. Another situation, the resisted test is not painful, but there is clear weakness. Perhaps the patient has pain, but the test itself doesn't influence the pain. But there is weakness. Well, in that case, we can think, for instance, of some kind of nervous involvement. There could be compression on nerve root, there could be a neuritis. And another situation where you find in your clinical examination that practically all of the resisted tests you perform, they seem to be painful. This is very unlikely. If that is the case, you could think of some malignant problems, but of course we have to compare left and right, and we also see that patients where the psychosocial component is pretty dominant, they like to react positive on a series of resisted tests. So keep in mind those details, because that's pretty important to reach a valid diagnosis. But another little detail, resisted tests, or let's say during a resisted test, we can also exert pressure or compression on some inert structures. For instance, a bursa. And that's something we see very often. In case of a bursitis in the shoulder or a bursitis in the hip, very often we see that several resisted tests are inconsistently positive. And what do I mean by that? Sometimes they are positive, sometimes they are negative. It depends from the position from which you perform the resisted test. There's no contractile structure, there is no tendinous pathology, there is no muscular pathology, but due to the compression on an inert structure during the contraction, we provoke some pain. So it's always interesting in that perspective to repeat your resisted test and to perform them from different positions and then see what happens. So I hope this was helpful for you, and let's see each other in the next film. Bye-bye.